Okay, I think I'll get us started. Hi, everyone. Thank you for joining us for the MSGERC Grand Rounds Webinar Series, Episode 3. The title of this series, episode is Invasive Mold Infections, Addressing Emerging Resistance. And we have three panelists, each of whom will present a case for discussion. I'm one of the panelists. My name is Jeremy Gold, and I'm a medical officer with CDC's Mycotic Diseases branch. We also have Dr. Thomas Patterson, a professor of medicine and chief of the Division of Infectious Diseases at the University of Texas Science Center in San Antonio. His clinical and research interests focus on the diagnosis and treatment of fungal diseases, especially in immunocompromised hosts. And we also have Dr. Nathan Wiederhold, who is a professor and director of the fungus testing laboratory at the University of Texas Health Science Center in San Antonio. And his research focuses on trends in antifungal resistance, new mechanisms of resistance in fungus, and in the evaluation of novel agents under development for treating invasive fungal infection. So I will start off with my case. Next slide, please. So I'll be talking about triazole-resistant Aspergillus fumigatus infections, how these infections are increasingly linked to environmental fungicide use, and how a triazole-resistant Aspergillus fumigatus infection linked to triazole fungicide use manifested in a case in Pennsylvania. And I forgot to mention also, if people have comments, please do feel free to put them in the chat, and we'll be checking that throughout the talk. So next slide, please. Antimicrobial resistant fungal infections with Aspergillus fumigatus were recently added to the watch list of CDC's antimicrobial threats report. Next slide. So some very quick background. Invasive aspergillosis is a rare life-threatening disease, most often caused by Aspergillus fumigatus, and mainly affecting severely immunocompromised patients. The global incidence of aspergillosis in humans has been steadily rising, and this is likely because of medical advancements leading to longer lifespans for immunocompromised people. Next slide. So we're seeing invasive aspergillosis increasingly identified in non-classic patient populations, especially in patients with severe COVID in the ICU setting. Next slide. Triazole antifungal drugs for treating invasive aspergillosis, including voriconazole, and in particular voriconazole, posaconazole, sabuconazole, and itraconazole were introduced during the 2000s and 2010s. And voriconazole in particular is the first-line treatment for invasive aspergillosis and has been associated with a pretty impressive improvement in patient survival. Next slide. Unfortunately, triazole-resistant Aspergillus fumigatus threatens successful treatment with these life-saving drugs. And the data on this slide are from a 5-year retrospective cohort study. It performed at 3 tertiary care university medical centers in the Netherlands, where basically they found that survival was 33% lower in patients with triazole-resistant versus susceptible invasive aspergillosis. Next slide, please. Now, of course, mine is freezing here. Oh, there we go. So there's strong evidence now that triazole resistance is driven in large part by the use of fungicides in the environment. And the molecule alignment and docking of some of these fungicides that to target enzymes are identical to those used in medically used azoles. So even though Aspergillus fumigatus itself isn't a plant pathogen, it's present throughout agricultural settings and then can develop resistance to medically important triazole drugs when the fungus is incidentally exposed. Next slide. So basically what this means is that patients can breathe in Aspergillus fumigatus spores that are already azole resistant, and they can develop invasive aspergillosis resistant to treatment. Next slide. Notably, in the early 90s and 2000s, 2 genotypes for triazole-resistant Aspergillus emerged or were discovered. And these genotypes, which for brevity's sake we call TR34 and TR46, they confer resistance to triazoles by altering the drug target, the CYP51A, which is involved in fungal cell synthesis. And importantly, the TR34 mutation confers resistance to all mold-active medical triazoles without incurring a fitness cost or survival disadvantage to the fungus. And Aspergillus with these genotypes are found in patients who've never before been treated with triazole drugs. And most patients who have the TR34 isolates haven't been exposed to triazole therapy before, suggesting that they've acquired the infection through inhalation of the spores from the environment. Next slide. And of concern, the use of fungicides in agriculture has increased about fourfold since the last period during which this was studied, so from 2006 to 2016. Fungicides are also used in a variety of other settings too, including gardening and industrial uses like wood preservation. Next slide. So the earliest hotspots for triazole fungicide resistance were found in the Netherlands related to the tulip industry, but environmentally driven triazole-resistant A. fumigatus isolates are now seen kind of everywhere across the globe, or at least in the places where scientists have gone looking for this issue. And the prevalence of aspergillosis cases that involve triazole resistance is over 20% in certain European healthcare settings. Next slide, please. And in the US, actually, we'll take a quick break. Thank you for not a break, but a discussion question that those in the audience, if they could answer. The question is, what percentage of Aspergillus species isolates at your institution is triazole resistant? And it says hosts and panelists cannot vote, so we're counting on the audience. And all right, I have the results here. It says that 51% of respondents don't know. This is out of 35 respondents. About 9% said none. 31% said 1 to 2%. 9% said between 2 or greater than 2 to 4%. And nobody said greater than 4%. So it seems like most people don't know. And I'm not surprised by that because in general, antifungal susceptibility testing for molds is not something that's frequently performed in US clinical laboratories, at least. Next slide, please. And yeah, so like, as I just mentioned, in the United States, surveillance data on azole-resistant Aspergillus fumigatus is really sparse. There's only been a small number of cases of patients infected with triazole resistance, but this might reflect a lack of AFS, antifungal susceptibility testing, rather than a true absence of this condition. And next slide. So with that background in mind, I'll quickly go over a case that we recently published. Basically, it's what we think is the first fatal invasive mold infection involving triazole-resistant Aspergillus fumigatus with one of the fungicide-associated mutations in the United States. So next slide. So in terms of the case, the patient was a 65-year-old man. He had a past medical history of acute myeloid leukemia and had received CAR T therapy. He also had a hematopoietic stem cell transplant 4 weeks before presentation to the hospital, which was complicated by graft versus host disease, treated with topical therapies. Next slide. So he was admitted to the ED, this is hospital day 1, coming in with worsening rash, fevers, and lethargy. And initially he was admitted to an inpatient ward and treated with broad spectrum antibacterial drugs and systemic corticosteroids. And at that time, they also continued his home fluconazole prophylaxis. Next slide. And on day 3, he was transferred to the intensive care unit for wound management and hypovolemic shock. At that point, they briefly changed his antifungal prophylaxis from fluconazole to posaconazole, and later he was switched to caspofungin. And during his ICU stay for the first 2 weeks, he gradually improved. Next slide, please. But on hospital day 23, the patient acutely decompensated, developing acute onset shock and hypoxemic respiratory failure. At that point, he was intubated and placed on mechanical ventilation. His chest CT showed evidence of multifocal pneumonia, and he had BAL cultures, bronchoalveolar lavage cultures that grew Aspergillus fumigatus, and who was begun on voriconazole. Next slide, please. So on day 27, the patient further decompensated, developing progressive acidemia, refractory hypotension, and focal neurologic deficits. And on that day, also a skin culture collected grew positive for Rhizopus species. And given how much worse the patient was getting, the family decided to transition his goals of care to focus on comfort measures only. But on autopsy, the pathologist, an autopsy was performed and the pathologist determined that the patient had died from sepsis due to two disseminated fungal infections by Aspergillus fumigatus and Rhizopus. Next slide. So as part of kind of ongoing passive surveillance, the clinicians at this hospital sent a specimen from the patient's bronchial washings for testing at CDC. And CDC performed for the Aspergillus fumigatus specifically. And CDC performed broth microdilution to determine the MICs of itraconazole, which was greater than 16, and voriconazole, which was 2. And based on these values, the isolate was classified as voriconazole resistant in accordance with the CLSI MIC breakpoints. And for itraconazole, it was considered non-wild type based on proposed epidemiologic cutoffs. Next slide. So kind of just some take-home points from this case. So what we reported was a fatal disseminated fungal infection in an immunocompromised patient in the US that involved pan-triazole-resistant A. fumigatus. And I think what's particularly of note is that this Aspergillus fumigatus had the environmentally acquired TR34 mutation. And this is something that we hadn't seen much of in the United States before, and certainly not, we hadn't seen a reported death yet from this type of resistant infection. And kind of the take-home points are basically that we think clinicians should be aware of the possibility of triazole resistance in patients who don't seem to be improving with first-line therapy. And we also wanted to make clinicians aware that testing for azole resistance, including for the environmentally acquired mutations, is available for free for US facilities through the AR lab network. We're happy to provide more information on that. And kind of for in terms of future steps, we think it's really important. We're working towards developing broader clinical and environmental surveillance for triazole-resistant Aspergillus fumigatus. And that's really it for this case. I wanted to leave a little time for a question if people have any. Oh, and I see a few questions. One of them says, can you briefly describe the CDC's passive surveillance program, number of isolates, et cetera? Yeah, I'd be happy to. It's basically through the it's kind of, we have two surveillance programs for invasive mold infections at CDC. One is through the AR lab network. Excuse me. One is through the AR lab network. So basically, it's passive in the sense that we clinicians who have a patient with invasive Aspergillus with an A. fumigatus infection are welcome to just submit the isolates directly to CDC. And what we do is we monitor if for those isolates that have elevated MICs and test positive for the azole resistant, for the environmental mutations like TR34, we kind of fill out a standardized case report form and track those cases. At this point, we've tested about, it's still kind of in its earlier stages, and there's something we're trying to build up, but we've tested at least definitely over 200 isolates. I should have pulled the numbers before I got on here, but and we've detected 2 resistant cases so far, one of which had the TR34 mutation. This is in the past year, but really I think the issue is we don't have enough isolate. We're trying to drum up more isolates to get kind of more representative sampling. So if those on this call have isolates that they're interested in testing or have concerns about azole resistant infections, we're very interested in hearing from you. How commonly are voriconazole resistant Aspergillus strains susceptible to posaconazole or savuconazole? That's a really good question, and the answer, at least in the United States, is we don't have the answer. That's part of why we need to build up better surveillance to understand sort of what is how common are these oh, sorry, the questions are flashing by fast. How common are these mutations in US clinical samples, and what kind of mutations are patients getting? Because there's depending on the type of mutation, the resistance profile of the organism is different. So
hey, Jeremy,
do you want to comment? Yeah, please.
Yeah, sure. And so kind of going back to that question about how common they are. And so we recently published our experience over a 52-month period, and it contained over 1,000 Aspergillus fumigatus isolates. And over that period, the resistance to all the azoles was between 3 to 4%. Now, with regard to voriconazole and isavuconazole, if you see resistance to voriconazole, the isavuconazole MIC is also going to be elevated. Those MICs and Aspergillus seem to parallel each other. That's not the case for posaconazole as well as itraconazole, which can be affected by different mutations. So it really just depends upon the point mutation within the CYP51A gene.
I might comment too that TR34, the one that's panazole resistance, worldwide has been more common than the TR46, which seems to be more associated to resistance for voriconazole and isavuconazole. But as Nathan really sort of implied, that you can also get resistance through other mechanisms. And so, you know, it's important to keep that in mind as well. And so with that, you might see susceptibility to posaconazole, for example, when you had resistance to voriconazole.
Oh, and which azoles, they asked which azoles are tested for resistance. Through the CDC program right now, we're testing itraconazole and voriconazole usually, or always voriconazole and itraconazole. And I'm not sure if it might depend on the individual circumstances, but those are the ones we always test for. All right, and I think we're on to our next panelist, and I'm blanking right now. Tom, is that you or is it Nathan?
Oh, no, it's me.
Okay, great, thank you. I've been having trouble lately, so please.
Yeah, so my case is a little different, but also deals with resistant infections, keeping with our mold resistant theme. So this is a case of an orthopedic device-related infection after a terrible motorcycle accident. Next slide. Slide shows my disclosures. I think it's in your materials as well. So the case presentation starts here as a 58-year-old man with no prior medical history, although he had a lot of motorcycle wrecks, and a really bad one in 2016, but he'd had several more before that. Required multiple surgical procedures, including a prosthetic joint replacement and revisions, really a bunch of them. He developed an infection, at least one in January of 2019, which was a methicillin susceptible Staph aureus infection, treated with cefazolin for 6 weeks, followed by doxycycline oral tail, because really he had so many procedures that total removal of the hardware really was felt orthopedically not to be possible. He complained of increased erythema and drainage from the knee in October of that year. He was afebrile, but had a lot of fatigue, decreased energy, and new swelling of his right knee with a draining sinus. I don't have a picture of it then. We didn't see him at that point in time, but he underwent, as I said, surgical drainage and partial removal of the hardware. Next slide, please. So now the cultures from the surgical procedure were positive for fungus. Later identified as Lamentaspora prolificans, but no bacteria was identified, although he was still taking a long-term doxy at that point in time. Fungal susceptibility was requested. It was sent to the fungus testing lab where Nathan tested it and basically showed, as is really very typical for Lamentaspora, cross-resistant to all the antifungals that were tested. And Patterson, super high MIC, fluconazole was requested, so they tested it. You wouldn't expect it to be susceptible. Mycopungin, itraconazole, posaconazole, and voriconazole had an MIC of 16, so obviously really high, but not very promising results. Next. So what is Lamentaspora? Just real briefly, it's formerly called Scedosporium prolificans. It's been phenotypically and morphologically distinct from Scedosporium, so now it's called Lamentaspora. There's a culture growth there showing the black growth that you'll see on the plate, and then the typical canidia in the upper part of the panel. It's resistant to most antifungals, associated with malignancy, organ transplant, trauma, cystic fibrosis, And obviously our man had trauma as his initial source. Clinically, the presentation can be disseminated infection. Pulmonary can also occur, but bone and joint infection is really not uncommon. Next slide. So here's some typical susceptibility data. These are from the website you can see there from Australia, where these infections are particularly common. These seem pretty geographically distinct in Australia, in the US, but also in Spain, has reported a number of these isolates. And you can see that typically resistant isolates would be found for amphotericin, sabuconazole, not many tested, voriconazole with high MICs, posaconazole, and itra. In some areas of the world, terbinafine and voriconazole are used together. In Australia, there's been a pretty substantial experience with that combination. And you can see, based on typical susceptibility synergy studies, which we could have another debate if those are really that useful, but you can see that in vitro was actually, it seemed to be synergistic in that setting. Next, please. So what about newer agents, investigational agents? And I'm going to show you a couple. So one is fosmanogepix, previously known as the APX001, which does seem to have efficacy, at least in vitro and in vivo. This slide shows a number of different models from Candida, Aspergillus, Fusarium. It does have activity against Candida auris, which is kind of one of its early calling cards, where higher doses may be effective. But it has been looked at in clinical efficacy, and the clinicaltrials.gov number that's shown there on the slide. For patients with refractory intolerant infection, patients who are either having refractory infection or intolerant to available antifungals. And lamentaspora, as I mentioned, does seem to have good activity with a really low MIC in vitro and in a murine model. Next, please. The other agent that we were looking at in the clinic was alorfilm, the F2G compound with the number shown there. Alorfilm is a potent inhibitor of dihydroorotate dehydrogenase, so it's a new target, just like the new class of drugs that are as shown by the fosmanogepix. Obviously, there are different mechanisms for these two agents, but this mechanism was identified using genetic studies and nidulans, confirmed in vitro assays. And basically, humans have this enzyme, but it's markedly different in terms of the affinity between human and fungal enzyme. So it's highly active. This agent is against many molds and endemics, and I'll show a little of that on the next slide. So in vivo activity, mostly murine, and now in the clinic has been shown for Aspergillus species, including resistant organisms, Scedosporium, Apiospermum, Pseudalscherdiboidii, and lamentaspora. And also, interestingly, the endemic coccidioidomycosis, where we showed in our animal model that it would even sterilize the brain. So a number of different models have shown this activity. And on the theme of resistant Aspergillus, you can see in this study that you were able to have good activity for this agent, even for resistant Aspergillus species. So open label refractory and resistant infection study is nearing completion, and other studies are in progress. So this slide shows the microbiologic activity for alorfilm. It has really consistent low MICs with a unimodal distribution for Aspergillus, lamentaspora, Scedosporium, Scopulariopsis, Coccidioides, and Histo, as I mentioned. And it's fairly predictable in which cases you can see resistance. So this slide shared with from Dr. John Rex at F2G basically shows that you really have good activity. You can see Lamentaspora here in the purple with really no isolates or very few isolates that would be predicted to be resistant. Next. So the in vivo activity of Burstgetosporium and Lamentaspora is shown here. And again, you see really good activity compared to untreated control animals of all three of the agents, including Lamentaspora prolificans. So back to our case. So this patient was initially treated with voriconazole, sort of on a hope and a prayer that it might work with an MIC that was obviously very high, but he had very poor clinical response and was referred for investigational therapy. The patient did receive alorifim despite COVID being rampant at that point in time, with therapy begun in March of 2020 with really good resolution of drainage, improved swelling and pain, and now more than a year in, you can basically see where the draining sinus was, like above his knee, but really the swelling had markedly decreased and no more drainage was occurring, and he was able to go about his business and work. So he really seemed to have a really remarkable response to the initiation of that therapy. Next slide, please. So unfortunately, with the hardware still in place, he had increased drainage and recurrence of the swelling. Once again, he had partial hardware removal and drainage. This is a post-operative picture. Cultures then were positive for coagulation negative staph, but also Lamentaspora. Interestingly, the MIC was initially that 0.125, and it stayed that exact number, so it didn't develop resistance at all. We hope that the coagulation negative staph was playing a major role. He was treated with vancomycin, again followed by doxycycline, and continued on alorifim. Next slide, please. So he did initially improve, but now you can see that he's developed these subcutaneous nodules there on his medial part of his leg. It's also right above his kneecap. Again, with hardware still in place, it wasn't a result that was particularly unexpected. And unfortunately, earlier this month, he had to undergo above the knee amputation. Cultures, interestingly, were negative for Lamentaspora this time, and margins really didn't show any osteotes. We plan to continue the alorifim for another 3 months because we know what a difficult infection this can be and how devastating it would be if it recurred. Next slide, please. So just to summarize the points on this case, resistant refractory fungal infection after trauma. It's certainly not very common, but we've seen it in the past, and this is a very difficult organism to deal with simply because it's not susceptible to most antifungals. Investigational agents may offer favorable treatment options, and it's an example of the use of alorifim in this setting. And others with activity like the phosphomanogenics might as well. I think it's really important to recognize the importance of source control in treating infection, and that's obviously what likely led to his eventual failure. So with that, I'll stop and turn to Jeremy for the poll question.
Unmute. Okay. So this is the polling question for those in the audience. Have you seen this type of infection in your practice? We'll give it a minute, or not a minute, but we'll give it a little, maybe 20 seconds or so. Right. And so out of 38 respondents, 82% have not seen it, and 18%, 7 out of 38 or 18% have seen a similar infection in their practice.
Maybe more seen it than I thought.
Yeah, I wasn't sure if that would surprise you which way, but yeah, keep going. And we'll see if there's any, I don't see any questions popping up just yet. I'm very excited about Lorifem. I think that's like, we get so few new antifungals in the pipeline. Oh, there's a raised hand. I'm sorry. Let's see where. Oh yeah, Tom. Yeah, feel free to unmute and ask if someone wants to ask a question from the audience.
Yeah. So
I can't seem to see it.
So Dr. Cower was saying, why was the hardware not removed? Well, I didn't give a whole lot of the previous history, but he had so many procedures on his knee, and his leg was in such bad shape that they just felt like they couldn't totally remove the hardware. And so I would say that's what we were concerned that it would eventually, recur, and it did. The question is, what did the pathology reveal? The nodules went away. So those nodules, were initially had resolved, and they really weren't there. But it really didn't. The path didn't show any osteo. Actually, it showed old granulomas and granulation tissue. So I think the question is, can you rely on MICs? We don't have a lot of clinical correlation data, but I think this is a good example of a time that we know these high MICs correlate with general badness and poor outcomes, right? So that's why the lab shows that no breakpoints part. And even for these investigational agents, they will sometimes have to read the results in various endpoints because you don't really know. So I think that's why the clinicians caring for the patient actually tried the VORI. They didn't use terbinafine. We weren't involved in the case at that time. We haven't had very much success with the terbinafine as well. But I think with newer agents that are very specific, as Jeremy says, he really likes the Lorifem for molds. But again, I didn't emphasize it doesn't cover yeast really at all, right? So that's really one of its issues. So fungal diagnosis becomes really important. You really need to establish a diagnosis, whether that's with tissue, or other, non-culture based testing, maybe even PCR and the like, to try to really establish a firm etiology. And the same is true for the Managepics, where the really good activity for the organisms it covers, but there's some organisms that don't have the target. So you end up not really having activity against all species. And so that's one of the reasons you're really going to have to focus on a good diagnosis in using these newer agents. You want to make any comments on susceptibility for molds, Nathan?
Sure. So one of the questions is there standards for testing antifungal drugs against filamentous fungi? And yes, there actually are, both in Europe under UCAST and here in the United States and North America with CLSI, standards are published. For UCAST, you can do a quick Google search, UCAST antifungal susceptibility testing, then you'll go straight to their website and have all the resources readily available. For CLSI, you can also go to their website. They do have standards available for both yeast as well as for filamentous fungi, but you do have to pay for those particular standards. Another question is do the results of antifungal susceptibility testing correlate with clinical outcomes? It depends. For yeast, I think there's clear evidence to show that MIC results, there are correlations. For filamentous fungi, it's somewhat of a different picture. It has been shown for Aspergillus fumigatus and the azoles. CLSI now has a breakpoint for voriconazole and Aspergillus fumigatus, as Jeremy mentioned earlier. For other fungi, such as Fusarium, I think the jury is still out, although the most recent ECMM guidelines for rare molds don't recommend susceptibility testing of antifungals against Fusarium because there have been some studies showing a lack of correlation. And so it really is species dependent when we talk about filamentous fungi.
It looks like we got a question about how good bone penetration is for Olorofin. I don't know if we have that information, but it's an interesting question. Yeah.
I don't know the answer to that one. Tom, do you know?
I think it's good, but I'm looking it up right this second.
And while you're looking at that, you might, in the search, you might come across, there's another person asking kind of what dosing of Olorofin was used and what was there discussion of using more aggressive dosing, whatever that means, because of the retained soil. Yeah,
well,
I guess these are
that is also a good a good question. So I didn't really want the, we really are talking about resistant molds and not so much Olorofin per se. Obviously, that's what we're talking about. And so the first question is, what about bone penetration? Bone penetration is good. It looks like the ratio from tissue to plasma is for bone surface is but range between 1 and 0.7 for males and 5 for females. So it's good. The distribution is really wide, including brain and bone. So that may be an advantage moving forward and something that we could definitely use clinically. I didn't get into the levels. Originally, this protocol used levels because so little was known. And less was known when he started therapy, right? Because that was early in the pandemic, which is 30 years ago now. His dose actually got increased. So he was on a lower dose, he was on the standard dose, and he got a higher dose. But throughout, his levels were good. And since it was part of an ongoing clinical trial, he had a lot of levels measured. And so he did take the drug, and it had good bioavailability, which would be predicted. We didn't get any bone levels. I guess that would have been interesting from the surgery, but he lives way distant from San Antonio.
These are great questions. I'm trying to see if there's any did I miss any here? They're coming so rapid fire. Oh, Valerie Ravena pointed out that if you have questions about Olorofin, they can send questions to medinfo@f2g.com. We will not misread the email address. I think we've covered all the questions for this one. Shall we move on to Nathan's case or to Dr. Wiederhold?
Sure. Thank you.
All right, so for this last presentation, we're going to be talking about something new that we've started to see here in our laboratory, but definitely something that's not new in other parts of the world. So next slide, please. So for dermatophytes and dermatophytosis, as you know, these are slow-growing molds that have the ability to invade keratinized tissue. For dermatophytosis, there are several different genera that can cause these types of infections, but the ones that are most prominently seen are caused by members of the trichophidans, such as T. rubrum, T. mentagrophytes, and T. interdigitale. Now, the reason that dermatophytosis is so important is because it's actually the most common fungal infection in the world. Some studies have estimated that it affects about 25% of the general population. Next slide, please. So in terms of treatment, if there's limited disease, most would use a topical therapy. and there's an abundance of available agents, from the azoles to the allylamines and to other agents as well. However, if the infection is extensive or refractory, then most clinicians will switch to an oral therapy, including itraconazole, sometimes fluconazole, depending on the patient, terbinafine, as well as griseofulvin. However, if fluconazole or griseofulvin is used, it might require a longer course. Next slide. So what I'd like to do now in the next two slides are talk about some recent cases that have been published talking about treatment-resistant dermatophytosis here in the United States. The first one is a case that was published in 2020. It was due to a Trichophidon rubrum. So this was a 45-year-old male with onychomycosis of all toenails and tinea corporis that was quite extensive. It actually had this type of infection for about 20 years. Past medical history also of a portal vein thrombosis. And the reason that this is important is he was on apixaban, which is a factor 10A inhibitor. He had failed multiple therapies, including oral terbinafine and topical naphthafine, both which target the same thing, the squalene epoxidase. And he actually had failed another 3-month course of terbinafine and topical cyclopirox upon initial presentation, but had mild improvement with 1 month of griseofulvin. The clinicians had decided at that point to avoid itraconazole because of a drug-drug interaction with apixaban, itraconazole being an inhibitor of cytochrome P453A4, while apixaban is a substrate, and so therefore there was the increased risk of bleeding. T. rubrum was cultured from the skin scrapings, and this one had a particularly high terbinafine MIC of greater than 0.5 micrograms per mil, but the fluconazole MIC was fairly low. So because the patient had failed another course of terbinafine and only had mild improvement with griseofulvin, the anticoagulant was changed and the patient began on a 3-month course of oral itraconazole. Next slide, please. So the next case is a more recent one, published this year. It's actually still in press. This was a letter that was published in response to the previous case that we discussed. And this was a resistant dermatophytosis caused by Trichophidon mentagrophytes. So this was a 50-year-old male with no pertinent medical history who presented with a scaling plaque on the upper and lower extremities and had a terbinafine 250 milligrams once daily for 2 months. And so the picture there on the right-hand side actually shows the right knee after 2 months of terbinafine. So I think you can appreciate there really wasn't a clinical resolution. T-Mentag was cultured from the biopsy of the right arm, and then the patient was started on oral itraconazole plus topical cyclopirox. And then upon follow-up, 3 weeks later, had complete resolution of the symptoms. Unfortunately, there's no information on the terbinafine susceptibility profile that was provided. So we do see resistant dermatophytosis here in the United States, but not nearly to what's being seen in other countries. Next slide, please. So in parts of Southern Asia, there have been reports of dermatophytosis outbreaks that actually have reached epidemic levels in some areas. And these are recalcitrant diseases or unresponsive to typical therapies. Now, the trichophidon isolates that have been cultured have been shown to have increased virulence as well as terbinafine resistance. And we're going to go into that in a little bit more detail. In addition, they have extensive infections of the trunk and groin areas with frequent relapses and treatment failures. Now, many of these have been basically shown to be due to Trichophidon mentagrophytes genotype 8, which some have now claimed to be a brand new species of Trichophidon called Trichophidon indontinae. And these outbreaks have also coincided with the wide availability of topical combination creams that have a corticosteroid, an antifungal, as well as an antibacterial included. So next slide, please. So the first question have you seen these types of infections in your practice? We'll give you a few minutes or a little bit of time to answer this. Okay, so the vast majority, 6 to 8% no, but about a third have said yes. So that's actually kind of interesting. I had not expected it to be that high. Let's go on to the next one, please. If you are seeing dermatophytes, are you testing for them? Are you doing susceptibility testing for the azoles or terbinafine? Give you a little bit of time to answer. No, and that's what I expected. A lot of people don't do susceptibility testing for dermatophytes, but about 20% of the audience does. So, all right, we'll talk about that a little bit more. Let's go on to the next slide, please. So let's talk about the contribution of over-the-counter self-medication, specifically in the outbreaks that have been seen in Southern Asia, which have primarily been in India. And so, as noted before, these products contain triple combination steroids, antifungals, as well as antibiotics. Now, some of those that are available in Southern Asia actually contain steroids that are classified as US Group 1 super high or Group 2 high potency agents, such as clobetasol and betamethasone. Now, clobetasol is highly restricted in the United States actually because it has anabolic potential. But as you can see in the picture here, there are several creams that are available in parts of Asia and in South America and in parts of Europe as well that do contain clobetasol as well as other high potency steroids. Now, the reason that people like to use them is because it does give temporary resolution of symptoms, but it does allow for the proliferation of the dermatophyte and potentially for resistance to develop, of course. Next slide, please. Now, the lesions that have been associated with steroid use can be quite dramatic. So patients can present with double-edged or multi-edged tinea. This is called tinea pseudoimbricata, rings within rings. And those particular regions might be specific to topical steroid use. In other patients, the lesions can be quite large and have bizarre shapes. It might be multiple, closely juxtaposed, centrifugally spreading with eczematous centers. And so rather dramatic lesions in some of these reports. Next slide, please. In addition to the types of lesions, resistance, specifically terbinafine resistance, has been quite high. So this was a study published in 2020 in the journal Mycosis, in which they looked at 402 patients in 8 different locations in India. And they captured skin scrapings between 2017 and 2019. Most of the patients had infections on multiple parts of their body, and the duration ranged from being 2 weeks to up to 7 years. 81% of the participants did confirm using pharmaceutical agents before visiting a practitioner, and 72% applied topical steroid creams. Now, of the dermatophytes that they were able to grow from the skin scrapings, the vast majority, nearly 94%, were Trichophidum integraphytes, all of which were genotype 8 or Trichophidum indontinae. Next slide, please. And overall, terbinafine resistance was quite high. 72% of those T-Mintag isolates were resistant to terbinafine, which they classified as having an MIC of 0.5 micrograms per mil or higher. But resistance was also fairly high in those isolates that were T-rubrum, 44%. In addition to having high terbinafine resistance, azole resistance was seen in about a quarter of the isolates overall. Now, interestingly, terbinafine resistance was more common in the azole susceptible isolates than in the azole resistant isolates. They're not quite sure why that might be, but the authors speculated that it could be that those creams that had terbinafine lacked an azole, whereas those that had an azole lacked terbinafine. So it's kind of one of those if one bucket or the other situations. Next slide, please. Now, these types of infections, the T MinTag with terbinafine resistance has now started to spread. It's been seen in parts of Europe, within Iran, other parts of the Middle East, as well as in Russia. And again, these are isolates that have very high terbinafine MICs and are associated with very specific point mutations within the squalene epoxidase gene. Next slide, please. Unfortunately, when you start to get into these types of infections, the treatment with other medications can be somewhat suboptimal. So this was a study of patients with chronic or chronic relapsing tinea infections, and enrolled about 200 patients, 50 of which were in each oral treatment group, which was fluconazole, itraconazole, griseofulvin, and terbinafine. Now, after a month of treatment, only 8% of patients that were included had a response. And even after 2 months, 8 weeks of therapy, response rates were still somewhat suboptimal. For itraconazole, only about 66% of patients actually responded, much lower for griseofulvin as well as for terbinafine, as expected. So what are we seeing here in the United States? Let's go to the next slide. So this is some experience that we've had here in the fungus testing lab. We serve as a reference lab for institutions across the US and then in other parts of North America. So since 2020, we've started to see an increase in terbinafine resistance. We've actually now confirmed 11 trichophidin indotiniae or T MinTag genotype 8 isolates, 10 since 2020, and
Oh, no, Nathan, I think
Is
he
it frozen
froze.
for just me or?
No, he froze.
Oh, that we were at such an exciting point in the talk too.
Oh, it was.
It was on the edge of my seat. I wonder, let me
Let
think.
me text him.
Thank you, Tom. I can fill this space by saying, firstly, I feel that dermatophytes and dermatophyte resistance, at least in mycotic diseases branch at CDC, this is an area that we really weren't paying attention to as much. Like we were so focused on invasive, and at least we're very focused on invasive mold infections, invasive candidiasis, because those are the most deadly. But the burden of dermatophytes, dermatophytoses, and the potential public health threat from resistant dermatophytoses is really nothing to is something we're getting increasingly concerned of, especially in light of what we've been hearing that Nathan's been seeing in his lab.
Well, I think too that real problem is, not only do you not test for susceptibility very often, but I think so many times clinicians don't even culture.
That's absolutely right. And even beyond that, like, I mean, we're one of the research projects, one of our analyses is basically showing like they didn't even do diagnostic testing for cutaneous fungal infections is really infrequently performed. And that's, it's a problem for a number of reasons. Like if you're going to not test someone, not, confirm that they have a fungal nail infection, but give somebody 3 months of terbinafine that, at least in theory, is pretty concerning from an antifungal stewardship point of view. And also you might be missing some other diagnosis that's not a fungal nail infection entirely. So there's lots to discuss there. Hopefully Nathan will be back soon though, because he'd be the one to discuss it more eloquently than I would. Oh, there we go. Nathan, we were just saying that it cut off right at like a pivotal moment in your talk. Are you able to
can you hear me now?
Yep.
Yes.
Yep.
Okay, sorry. Yeah, I have to join by phone. My computer froze up. So, all right. So, this was the last slide. Just was showing our experience where we've had an increase in terbinafine-resistant trichophana isolates, including several trichophana indontinae over the last year, with a really big increase this year. So with that, I think we would be able to open up the questions.
Yeah, so we were just talking while you were away, we were talking about, not only do people not test for, resistance, but really so often you don't even culture. Clinicians will often just treat and not even know exactly what organisms are dealing with. And Jeremy was pointing out that you could end up with mixed infections, other things, that really cultures would be useful to get.
Yeah, I mean, this is really an area we're interested in mycotic diseases at CDC, is sort of like doing some sort of like broader epi studies to understand what is the scope of this problem, of terbinafine resistant or antifungal resistant cutaneous fungal infections of all sorts, and what are kind of like the pressure points here in the United States that might be driving resistance, and to what extent is this a problem that we may, just be seeing the tip of the iceberg. And it looks like we have a question from Hamid Badali. How about host genetic susceptibility? I don't know if Nathan, if you have any thoughts on that. I'm not sure I do, but
yeah, I know Hamid, and I know he's probably referring. There was a case report, actually a case series out of Iran, specifically a family that had come down with this type of trichophana infection. And I'm not quite sure. Hamid's one of the authors on that, so he might be able to tell us in the discussion whether or not they found a genetic predisposition. But in most of the ones that have been seen in India, it's the most fingers are pointing to the use of the high potency corticosteroids as over-the-counter products, and so. It would be very interesting to see just how well a genetic predisposition might correlate with that. But at least in the outbreak so far in Southern Asia, it's primarily been linked with the use of those steroids.
And we have a question from, oh my gosh, I don't want to mispronounce the name. We have a question, do you always treat these infections? And are there cases where you would prefer not treating? And if so, what is your first line agent? Always culture or treat first, and culture if fails? I suppose it's sort of it's a how do you manage these infections, I think is what the question is really getting at.
Sure. Tom, do you want to weigh in on that?
Yeah, well, I think, obviously, if you look at those pictures that Nathan showed, you're definitely going to treat those, right? You're probably going to use terbinafine as your go-to agent. If it's really mild disease, you might not culture it, and you'd also probably start with topical agents. But I think you can surely see the downside of not really knowing what you're dealing with. Another question is, are these cultures sent out for major medical centers, or can they be performed in-house? And I'm not sure most clinical labs can readily culture these because it takes a lot of time. Do you know, Nathan? I don't know for sure.
Yeah, I mean, when we're talking about skin and skin scrapings or either onychomycosis, where you're collecting, parts of the toenail, you always have to be worried about things that are also going to be within those specimens, specifically bacteria. And so what our practice is, when we've done studies with this, we're plating them onto agar, basically that contains cyclohexamide and possibly other antibiotics to try to reduce the bacterial growth. And they are slow growing. And so this is not something where you're going to plate and then see growth that the next day or the next day. Sometimes you have to hold it for a few weeks in order for you to see enough growth. And so this is not a very rapid culture at all.
I'm curious, Nathan, like I've been hearing more about people using like PCR techniques and PCR techniques to determine like squalene epoxidase mutations and stuff like that. Like, what do you have any general thoughts on that approach? Because it could be faster, but I'm sure there's a lot of noise and you can't tell if it's like a live organism. I was wondering if you could comment on if you had any thoughts on that versus culture.
There is a product, I believe, available in Europe, specifically looking at dermatophytes that's PCR based. It's not available here in the United States. So anything that a lab might do in terms of that's going to be a laboratory developed test. And so we still use phenotypic testing for terbinafine as well as for the azole. So we're doing susceptibility testing. Even if you were going to do PCR on the culture, you're still going to have to wait for there to be enough growth on the culture. I'm not too familiar with direct specimen testing with PCR and what that practice is in the United States, but I don't think there are a lot of labs that are offering that right now.
Do fungal moldy libraries have dermatophytes in them?
They have some, yes, they have some. They would have T. rubrum, T. mentag, but I know that the two that have approval for FDA cleared databases here in the United States, they do not have that genotype 8 or Trichophidin indontinae available yet. So,
and great. And I just realized we're right at the time, so I'm sure everyone probably has to get on to their next meeting. But I think firstly, I wanted to thank Nathan and Thomas, and well, I guess I won't thank myself because I'm also on the panel, but thanking everyone who joined the panels today, and Lisa and Tom also for helping us to put this together and think through the cases, and to thank everyone for joining. If you have, I'd be very happy to hear from anyone who has questions about the presentation. And my email is leo3@cdc.gov or jgold@cdc.gov. And I think emerging mold resistance is definitely an important public health concern, and we were happy we got to share sort of three very different cases, kind of highlighting those concerns and some kind of like future directions for what we need to better understand about these infections. So just want to thank everyone for joining us today.